All right, well, welcome everyone tonight to tonight's Healthcare for All Oregon webinar about Medicaid and Marketplace changes that are happening as we speak. This is a busy month for a lot of folks, and there's a lot of emotion and tension and change in the air, and we're really excited that you are joining this webinar to have a conversation about all that. My name is Valdez Bravo. I use he, him, his pronouns, and I have the honor of serving as the president of Healthcare for All Oregon. Thank you for being here with us this evening. This is the fourth in a series of informational webinars where Healthcare for All Oregon seeks to really kind of come together and bring together some awesome panelists and all of you to have a discussion about the universal healthcare movement through the lens of a particular issue, constituency, or other topic. In the past, we've talked about the Taiwanese healthcare system. We've talked about the labor movement. We talked about veterans and how universal healthcare would uplift the lives of veterans, even if for those like me that have access to the VA. But tonight we're hitting it through an issue, and the issue is all these changes happening right now to our health system as a result of HR 1, the bill that passed last July 4th in 2025, and how it's affecting not only the Medicaid population and Medicaid funding, which you would be surprised at how ingrained that is across a lot of different aspects of our state, but how it's affecting everybody, frankly, with the end of the Affordable Care Act subsidies. And we're going to be hearing from some subject matter experts tonight and who are going to break it down for us. But first, for those of you that don't know about Healthcare for All Oregon, we are a 501c3 nonprofit organization, and we educate and advocate for an equitable, affordable, comprehensive, high-quality, public-funded healthcare system that will improve the lives of individuals, families, and communities, whole communities, and pretty much everyone across Oregon, and we hope throughout the United States. We really do believe that when we achieve universal healthcare here in Oregon, it will. This is the laboratory. This is the petri dish. This is the proving ground. Like so many other awesome things in medicine that have started in Oregon, it'll start here first and really spread. Again, for this fourth webinar, we're looking at these changes happening right now in the Medicaid and Marketplace. And we're just really excited to hear from Shanon Saldivar, one of our board members who works in insurance, and she can tell you more about her perspective, background, and what she's seeing on the front line. So thank you, Shanon Saldivar, owner of Saldivar Insurance and HCAO board member. We're also going to be hearing from Clackamas Free Clinic and Project Access Now about how they're reacting and adapting to the current healthcare landscape. So we're just super excited to have this fantastic panel tonight of Shanon, Lisa Steenson, Executive Director of the Clackamas Free Clinic and Volunteers in Medicine, and Tracy Carver, President and CEO of Project Access Now. Towards the end, we're going to have a Q&A session at the end. So you will have a chance to raise your hand and ask those questions at the end. But in the meantime, as our panelists are sharing out, if you have a question pop for you, feel free to put it in the chat or make a note if you want, at home there. But at the end, after we hear from all three speakers, we will move to that Q&A session, and your questions will be answered by our awesome panelists. But please put it in the chat, and we will make sure that we don't miss it. We're going to make sure that as much as we can, the time permitting, that everyone's questions are answered, and we're super excited. So without further ado, we're going to go to Shanon Saldivar, owner of Saldivar Insurance and Healthcare for All Oregon board member. Thanks for being here tonight, Shanon.
Hi, yeah, thank you for having me. Thank you all. I'm looking forward to sharing. My name is Shanon Saldivar. I am here in the Gorge. I'm in the Dalles and Hood Rivers, this is our main area, and we are coming out of spending the last 2.5 months helping folks navigate this extremely challenging landscape. I have some slides that we will pop up. Perfect. So I'm going to be talking about HR 1 impacts to the marketplace and Medicaid. This is going to be for folks who don't have access to group insurance. They also aren't Medicare eligible. So folks that are buying their own insurance through healthcare.gov, through our local marketplace. And some of the things I'll be covering is those enhanced premium tax credits ending, the affordability factor changing. So even folks who are still eligible, changes to that, how folks might be needing to repay tax credits come the end of the year, and then Medicaid changes to renewal and some other not great things going on. So next slide, please. So one of the extremely complex things here is when we are meeting with folks, Folks are trying to figure out what their income is going to be for 2026. So, like I said, we're coming out of open enrollment. We've been meeting with folks since November, and all of these things apply to 2026. So, consumers have their 2024 tax return. They don't know quite yet what 2025 is going to look like, and they're trying to forecast what 2026 is going to be at the end of the year, which is really challenging. And if they get it wrong or underestimate, can cause some really big penalties at the end of the year. Next slide, please. So the first big change is enhanced premium tax credit sunsetting. Within the Affordable Care Act, families could be eligible for some credits to help them pay for the cost of health insurance. Those tax credits were based on how much money families make and what the insurance cost them. And if the amount to insure them was above a certain threshold, they would get some tax credits to help them pay for that. It was a gradual decrease in credits the more money a family made. So a family could make about $10,000 more per year and lose about $1,000 in tax credits. Seems fairly reasonable. With these changes, families who make more than 400% of the federal poverty level, which are listed here, a single person, that's about 62,000, family of three, 106,000, they're losing all of their tax credits. So when they get into renew, or when they did get into renew this year, coming up on the end of open enrollment tomorrow, they're seeing some really big surprises as they're no longer eligible for those tax credits. Next slide, please. Folks who are still eligible for tax credit, so they're less than that 400% of the federal poverty level. That affordability factor the federal government has used to decide how much tax credit a family would get and how much a family should be able to pay for their health insurance went up. So the federal government now thinks a family should be able to pay more for their health insurance, which means their tax credit's going down, their premiums are going up. And we're seeing that $50 to $200 per month per person on average for folks that are still getting those tax credits, but just unfortunately having to pay a lot more for their coverage. This is in line with a lot of our families that have not received tax credits historically, because as we know, those premiums increase every single year. So those unsubsidized families have been feeling this every single year. Next slide, please. This is some examples of the increases we've seen. So these are families right here in the Gorge who've lost tax credits. That first star point right here in the Dalles, a family of two, retired early, making $100,000 a year. They were paying $80 a month for their premium, and it went up to $2,300 starting January 1. My bottom star there, a family out in Parkdale, family of four, making about $140,000. Premium went from $333 up to $2,100. We got some really frantic calls in January when folks got those bills in the mail or had that come out of their checking account too. So really, really big changes. Next slide, please. These are some examples of families who are still receiving tax credits, but they're receiving less tax credit. And what we saw is nothing has changed for these families, right? They're making the same amount of money. And most of our families who have been receiving subsidies have had fairly level premiums, because as the premiums creep up, typically those tax credits creep up proportionally as well. So for the last 4 or 5 years, it's been fairly business as usual for our families until this year, and it's caught quite a few folks off guard who weren't expecting these big increases. Next slide, please. Another big change due to HR 1 is changes to repayment. So inevitably, you're going to make mistakes or you're going to receive some income you weren't expecting. Again, we're forecasting into 2026. There have been caps on how much a family would have to repay if they made more money than what they had assumed and received tax credits for that, that income. And those are going away. So folks will be required to pay back all of the tax credit they're required to. And for some of our families, especially right over that 400% of the federal poverty level, if these families make $1 over that cliff, they owe back all of their tax credits. And as you saw, for some people, that would be $2,000 a month or over $25,000 a year that they'd wind up owing at tax time in 2027 when they're filing their 2026 tax return. It significant impact. Next slide, please. So how are Oregonians navigating this? Said we're coming out of open enrollment, and what we're seeing right now is about 10 to 15% of families are just canceling their insurance. They can't afford it. It is really expensive. Folks are going out to look for alternatives, and we're seeing folks land on this cut rate plans like indemnity or health share that don't have ACA protection, so they don't have those standardized benefits. You can't be certain that they have an out-of-pocket max that's going to hold. We've had folks in the past who've purchased these really happy with the premium, but not realizing it's not going to cover the thing they need when it actually comes down to it. Folks are going without care, going without their prescriptions. And then one big shift we saw here locally in the Gorge is that folks are changing to the least expensive carrier in the area. Sometimes it doesn't cover their local hospital. So we're seeing people still having insurance, still paying for it, but unfortunately not being able to access care in their local area. Next slide, please. So I'm going to switch gears a little bit and talk about Medicaid or Oregon Health Plan, and just kind of to set the ground level here. These income limits I have listed here are income limits. If folks make under these amounts, they could be eligible for Medicaid, Standard Oregon Health Plan, or the Oregon Bridge Program in Oregon. $1,800 for a single person, up to $2,600 for the Bridge Program for a family of one. Next slide, please. In Oregon, folks go through a process where they need to renew annually or every 2 years. Oregon implemented a continuous eligibility, which extends folks' renewal time to a 24-month time frame, recognizing a lot of times when consumers have to go through extra steps or hoops, they tend to lose coverage. And we have folks come into our office all the time with a huge packet of information that even as somebody who's in it and helps folks navigate this, it is extremely confusing. It is challenging to find what actually needs to be done. How do I get that in? What's my time frame? And that process right now is about every 1 to 2 years that Oregonians have to go through that to retain their Medicaid or Oregon Health Plan benefits. With these HR 1 changes beginning January 2027, it's mandated that states renew every 6 months. So on a 6-month basis, those consumers are going to have to go through this extremely administratively burdensome and challenging process, in addition to layering in some extra requirements, proving they're working, volunteering, or going to school 80 hours a month. There were some estimates that OHA put out that about 200,000 folks will be losing their coverage in that first year. And another extremely challenging piece of this legislation is if folks can't make it through this process and wind up not being eligible for Medicaid, and that very well could be because they didn't get the right paper to the right place at the right time through the right channel, and Medicaid benefits drop, they're also not eligible for premium tax credits. And that means they couldn't get subsidies to help them pay for the cost of insurance through healthcare.gov. So you're looking at families who were receiving free coverage essentially with Medicaid, no premium, no cost for services or very low cost for services, now going into plans that could be anywhere from a few $100 to $1,000 a month on top of a $10,000 deductible. Like, significant shift in what folks experience is going to be once these full regulations start kicking in 2027. Next slide, please. So kind of high level, lots of changes, really big changes for folks over that 400%, folks under 400% still having some changes to affordability. And then Medicaid is going to see some extreme changes, a lot, big increase in documentation and how folks navigate that to be able to retain their benefits. I think that's a nice segue to other folks on the call who are going to help share how are we trying to address this in Oregon and what are we doing. So.
Thank you so much, Shannon. I just really appreciate you, Shannon, your perspective. We at Healthcare for All Oregon obviously are fighting for a system where we don't have like insurance as part of this process of a universal healthcare single payer type system. But golly, I wish all insurance people were like you, because you're just like doing so much to help make sure that folks can get the care they need and navigate the system and help them out there in the gorge. So thank you so much. Really appreciate you and you signing up to bring your perspective to Healthcare for All Oregon. One thing I want to touch on before we go to Lisa is the fact that, as you're sitting here, I mean, this is the reality we have. I mean, we had our previous reality and now there's this new exacerbated, worsened reality because of the impacts of HR1 that Shannon's talking about here with these costs, and 15% of people or more, going out without care at all because of the cost. Just think about a world where the universal healthcare model that we're fighting, where how like so many of these things would not be even a factor, would not even be a consideration. The money in those budgets could be going towards groceries and school and rent and all the other things that we have in this expensive world we live in. The other thing is, I just wanted to editorialize also, like I work at the county health department. When you think health departments, you think about health promotion, disease prevention, those kind of things. So much of our work really though is safety net, the safety net that is required to like take care of folks because of this fragmented healthcare system where a lot of people just don't get care. They get only very basic care or emergent care, urgent care. And so much of the work we do every day at Multnomah County is really related to closing up and shoring up that safety net and making up for those gaps. But even with our federally qualified health centers, sometimes that's not even an option for folks. And so there's an even more low barrier model that Lisa Steenson is going to tell you about. And so I'm really thankful to welcome Lisa Steenson from the Clackamas Free Clinic. And Lisa, would you like to say hello first before we go to your video?
Sure. Yeah. Hi, everyone. Good evening. Thank you so much for having me. Before we tee up the video, I just want to, kind of center what I'm going to talk about a little bit tonight is the WHO. When I started out my career in public health as well, Valdez, I don't think I shared that. But I also was a patient advocate. I actually worked for a third-party administrator. I was basically a patient advocate when the provider, when it wasn't had the bill and the insurance wasn't going to pay the bill. And I was that middleman. And I learned a long time ago what this whole system was. And it's changed a lot since then. And since then, I've been helping connect people to services throughout my whole career, whether that's in housing, disability services, and now at the Clackamas Free Clinic. So before I get into my other remarks, I'd love to tee up a video just so you could learn a little bit about our organization, maybe be inspired about a community model. Really, what's the old adage? If you want to go far, go together. And really, that's the heart of our clinic. It was a community response in a time when uninsured was at 17% in this state. So going to just show who the people that make up our clinic, talk a little bit about our roots, and then talk about what it looks like day to day. So thank you, Valdez, if you want to hit play.
A group of community members identified a need in Clackamas County for health services for folks who did not have health insurance. They got together and they were able to find the resources needed to start this clinic. And in 2012, the doors opened and we've been serving folks ever since.
Most of our population in Oregon is insured now, but that still leaves thousands without means to pay for their care. Our clinic really serves as a safety net for that population, where we can provide essential primary care and other services that meet their needs. I truly believe that healthcare is a right, and our clinic is really only able to do that through your support.
Clackamas Free Clinic provides a pretty wide range of services, but our kind of main services are primary care, by which I mean treating chronic disease and preventing chronic disease. We have vision clinic. We also have periodic dental cleaning services. We have some counseling services, and we have a lifestyle medicine clinic.
So there are a lot of people who benefit from the services that we provide here. Number one is our patients, and we also see a lot of students through our doors. So the other students that we see a lot of are the medical assisting students here at Clackamas Community College.
The clinic community has been instrumental in my journey to medicine. When I first arrived, the providers were keen to teach and to explain their medical decision making, which is really beneficial as a student. Working at the free clinic, we work with a population that struggles with a lot of factors outside of just their health that can impact them, such as transportation or ability to pay for medications. Working in that environment gives you a lot of insight into the population that you serve that I think is unique in comparison to working at a bigger hospital system.
The Clackamas Free Clinic is vital because without health, it's difficult to complete any of the other goals in life. It's hard to keep a job and take care of your family and have positive relationships. Without good health, it's hard to enjoy life.
We keep people out of the ER. Healthcare spending will increase if we cease to exist. So the health of the community would definitely decline, and we'd notice more use of emergency services or just lack of services at all.
If somebody is thinking about volunteering at the clinic, I'd say call up, apply online, definitely talk to us, because we just need a wide range of folks, and you don't have to be a medical provider to volunteer at the clinic. There's a lot of need.
Well, Lisa, I'm ready to volunteer.
All right, sign on up. I'll have the website at the end. Thank you. I have some slides I'll share next.
All right.
All
Yeah.
right. Do you want me to drive or you want to drive?
I'm happy to drive if you'd like.
Okay, sure.
Okay.
Do you want to do the wide?
I
yeah,
will do the
there.
yeah, I will do the wide.
Perfect.
Okay, let me
Thank
share.
you.
Oh, I'm still sharing. Oh, sorry, I didn't realize I was still sharing. Sorry about that.
All right, you can go to the next slide. Yeah, so I hope that paints you a picture of who we are, what makes us see the faces of the clinic. Next slide. Again, back to our roots. So again, we were started in 2012 when uninsured rates were about 17%. So we were started by a community in response. So Providence, Willamette Falls, they were huge in our starting. It was a group of doctors in the community, the former mayor, concerned citizens got together and they founded the Founders Clinic. And we were in downtown Oregon City for a long time. And then about 2.5, oh yes, you see some familiar faces. About 2.5 years ago, we formed a partnership with Clackamas Community College. So we have a lot of students that our future healthcare workforce gets to get training through our clinic as well as serve the community. So it's a really win-win. But I always want to just acknowledge where we've come from and how we've evolved. Next slide. So again, you kind of heard a little bit about the primary care services that we provide throughout the week. We do not bill. We don't bill insurance. We are not a billable. Everything is for free. The only thing we charge for is prescription glasses. So sometimes on OHP, not all of their vision care is covered. So a lot of times folks will come to us for a free eye exam, and then we have a partnership with Oregon Lions. So if you ever donate your glasses, it does go to a good cause. But we do have to charge for that prescription. It's a hard cost. But we do vaccines, labs. We have our own in-house lab, imaging, ultrasounds. And then we spend a lot of time doing patient navigation. So a lot of times when people show up at our doors, it's because they don't know where else to go. And so there's just a lot of other needs. So we try to get referrals for lots of different services. So we're kind of that community hub for folks. Next slide. A little bit of our makeup, this is kind of just data that we recently pulled. So we are located out in Clackamas County, but people do come from all over. So we do see some Multnomah folks, Washington County. I think we pulled like 13 different zip codes. Shannon, we actually had someone from the other day that came from the Dalles. They had heard about us, it was totally 100% free and came our way. Our biggest thing that we see coming through our doors is chronic disease. So it's folks who are working primarily midlife. They're probably a caretaker. They don't have employer supported insurance for whatever reason. They don't qualify for OHP, but they make too much and can't afford Marketplace. That's our primary market. So of who comes to us and why they end up with us. Next slide. Next slide. Again, we only serve adults, so just have to be clear about that. Again, it's the uninsured, and then we will see folks who are underinsured for whatever reason. Maybe there's a long wait time for them. If they're getting on OHP, again, people go on and off. We will provide that bridge care, or someone has an immediate need. We absolutely will do what we can and then hopefully refer them on. Next slide. Okay, this is a big overwhelming graph, but I just want to point out again this gap and really highlight that there's this 200 to 400% range of folks. This is, again, that's why they end up in with us. And this is a huge population that is growing, which is, again, the conversation we're having tonight. Next slide. And click it one more time. So there are other free and charitable clinics up and down the I-5 corridor and in the state. So I just wanted to highlight some of our partners. We all operate independent. We're all privately funded. Again, we're free and charitable. There are some that offer some sliding scales and some that are 100% free. The free model is typically volunteer driven. We're a volunteer model. We have 6 staff and 140 volunteers. So we're able to provide the care that we can through our volunteers. If you just want to click all the way through, there's some more bullets, Valdez. Yeah, so I just want to highlight, if you go to the next slide, please. We are associated with the National Association of Free and Charitable Clinics. There are 1,400 free and charitable clinics across the United States. There are about 11 in the state of Oregon. There are 60 to our friends in the north in the state of Washington. And so why I want to highlight why this is important is we are the safety net of the safety nets as free and charitable clinics, but we don't have the infrastructure to handle what HR 1 is if it unrolls the way that it does. So I want to point out some of that kind of critical piece. We are expanding our services, and yes, our FQ friends obviously do serve uninsured folks as well. We are all a part of the ecosystem, but just some comparison. I want to highlight that as just an education moment. Next slide. Just from my vantage point, the landscape, just alone in our community where we're at, there's today 22,000 folks that lack coverage. I think Tracy might touch on more about access in her remarks, but insurance doesn't always equal access. We see that a lot in our clinic. Just the rising costs, which Shanon spoke to, provider shortages, and then the health equity gaps. So that's kind of how we look at it, a holistic, some of the challenges and the realities. And next slide. Some of the barriers, the biggest number one barrier we see why people can't access is transportation. Love the bus tickets and everything, but sometimes that doesn't work, especially if Clackamas County. We're rural and we're urban, and so it's this weird kind of transition point. Transportation is just a huge barrier to get to care. We know that recent data I pulled, Oregon kind of has like an average met need of primary care, but we know in rural areas that's just not the case. Wait times, this was pulled a while ago. I think it's much, this was pulled like 3 months ago. We heard is 3 months. But we know that number is growing. We know another barrier to care, especially folks who end up at our doorstep, is the navigation of the system. Yes, we know everyone's working on overdrive that works within the healthcare system, but people are confused and frustrated, especially with all the changes coming. And the last thing is just fear. We know there's real fear for our community out there right now in accessing care. We're a low barrier model that doesn't all we require is a name, birthday, and contact phone number. I know not every, some providers can do that, some can't for lots of different reasons, but just want to call it that fear is real. Next slide. Just a little anecdote from one of our patients. I love this place. It has been a big help. I would be dead if I hadn't received the help here. Before, I didn't pay attention to my health, but I learned a lot at the clinic. I quit smoking, drink more water, take things more seriously. Even though I have had insurance off and on over the years, I'm always welcome back. So I love that they said they're always welcome back. But again, I think this paints a picture that people go on and off of insurance. And so, yeah, so that's why we're here, to catch them when they're out. Next slide. Challenges ahead, we know demand and volume. I mean, it's overwhelming. I was on a call earlier. it's hard to even make sense of that. But from from a service provider standpoint, it's pretty overwhelming. We're seeing day to day, just right now, people are delaying care. We're seeing sicker, more complex patients coming through the doors for lots of reasons. A lot of donated care programs have gone away due to or lack of funding. The pace of all these changes is also overwhelming as a small service provider. Just keeping up on it. I mean, it's overwhelming for a lot of us but when you're trying to deliver on service and keep up with these changes, it's a lot. And then we're expected to kind of fill in the gaps, and that's overwhelming. There's just a lot of unknowns, and leadership, I'll let you interpret that how you wish. So next slide. Opportunities we see ahead, just how I see it. Again, we're access to care, expanding offerings, and then the big thing is partnership. We were started through partnership. Tracy and I partner on things. We partner with lots of other organizations. So yes, there are challenges, but there are opportunities to get through these days ahead. So we really need to stick together and partner as the demand goes up. I see opportunities in workforce development, especially our experience at the community college campus, and volunteerism. Again, whether you're volunteering at our clinic, you can get involved, especially if you have a licensed clinician. Please look at your neighborhood free clinic. Next slide. These are just a list of our partners. Again, it goes deep, and who we are. They're just critical to our success. And PANOW. I know lots of names I've probably left off, but the college, the county, Kaiser, Providence, Willamette Falls. Again, just critical to our success. We're all in this together. And then next slide. Okay, I'll leave you with this. This was just this past weekend. We had a free dental clinic in partnership. These are students, our next generation of healthcare workers. This was a free dental cleaning. These are future hygienists. We were able to give out 30 free dental cleanings to the community. We all know the importance of dental health. But look at those smiling faces. They were all excited to serve and give their time and learn along the way. So I'll leave you with that. Last slide is my contact information. If you want to go to the last slide, there's a QR code. I'm sure I can drop it in the chat. Feel free to reach out if you have more questions, if you want to get connected with the other free clinics. And thank you for your time.
Awesome. All right. Put your hands together for Lisa. Thank you so much, Lisa. And we are going to come back to questions at the end, but I did want to slip one in. Sounds like providers are volunteering. So providers in the area, if they're so inclined as they can reach out to you on this email here or go to your website, and it sounds like they can volunteer. And that's primarily who does it. You got 6 staff.
Yeah. And we do, we have a malpractice plan. So we do cover that. So that's covered when they volunteer with us. They just have to, and we do all the credentialing and everything. So we try to make it as easy as possible. So get in touch. Thank you.
Awesome. Thank you so much. So you heard it, folks. We've got these, we got these changes happening. We got folks driving all the way from the Dalles to Clackamas for the care, because that's the kind of world we're living in right now. And you got folks like Lisa in the free clinic. I'm looking forward to more in the conversation later on this evening, talking about like 11 in Oregon. Wow. And 60 in Washington. That's interesting. The system is going to get overwhelmed. It already is. So the next up, talking in that same vein about people that are trying to bridge the gap. That's the theme tonight. Medicaid and Medicare, these marketplace changes, bridging the gap. Project Access Now has been an organization that Tracy Carver, who we're so lucky to have here, CEO, is here with us to talk about. They've been bridging the gap for years. They're a partner of Healthcare for All Oregon. We're kind of like kindred spirits. We always like to joke that they're bridging the gap and covering down until we get to this future state where we have universal healthcare. I think Tracy and I both share the thought that we'd love to be out of a job. We'd love for people just to have healthcare. Wouldn't that be a great thing to happen? But in the meantime, that's not where we're at. So we're going to hear more now from Tracy Carver from Project Access Now, and I'll share my slides, Tracy, or your slides. I'll share your slides.
All right. Thank you, Valdez. And yeah, excited to be here tonight to talk with you all. And Tracy Carver, she, her pronouns, similar to Lisa and Valdez. And I didn't hear if you were the same, Shanon, but I also came from a background of public health and social services. So definitely kindred spirits, I think, in this space. So yeah, tonight I'm going to share a little bit about Project Access Now as an organization, as well as dive a little bit more into kind of what we're tracking and how we're trying to prepare for all of the things that are coming that you've just heard about here in the call tonight. So if we can go to the next slide. So Project Access Now was founded originally in 2007, so we have been around for almost 20 years. And in the original founding of the organization, our role was to organize donated care, specialty care for people that had no access to insurance, or in some cases were underinsured and not able to access some of the things that they needed. And I believe Lisa maybe shared the statistic as well. But at that time, before the Affordable Care Act and before Healthier Oregon, nearly 1 in 5 people in Oregon did not have insurance. So a similar population being served to who Lisa was speaking about, both people who kind of fall in the gap from making too much for Medicaid but not able to afford premiums. We also were serving a large percentage of the Healthier Oregon population at that time when they did not have the coverage that is available today. Fast forward, with the expanded coverage in Oregon, our donated care program is currently dormant due to reduced need and the funding that was previously available for that program being deprioritized by our funders. But I think we're very aware and tracking closely on what's happening in the landscape, and are recognizing that we may need to bring that program back depending on if things continue to follow the trajectory that we're worried they might. In addition to our long history of delivering donated care, we currently also have a insurance enrollment team that helps people every day get enrolled in insurance and understanding their insurance. And in a moment, I'll talk a little bit more about each of these. But just at a high level, you can see we're doing a lot around kind of helping people access and navigate their insurance. And then we also have a large community assistance program team that facilitates social supports for people at hospital discharge from some of the metro area hospitals, as well as CCOs. So if folks need a temporary motel stay to recover from surgery, or they need transportation, or they need food, that is what our community assistance program helps to facilitate and procure for them in real time so that they can discharge successfully and safely out of the hospital. And for CCOs, we do that similar work, but in support of their FLEX and HRSN programs. If we can go to the next slide. Project Access Now was originally founded to serve the metro area and did so predominantly serve the metro area for many years. And as we brought on programs over the years, you can see that our geographic scope has expanded to sort of program specific. So not every program we have is available in every region, but we do have expansion. And that's really just connected to where we have funding partners that are investing in us doing that work for them in their region, in part because a number of these programs, most notably our community assistance program, there are costs there that we cannot cover, which is donations or grants. We really need to have a partnership with entities that can help support some of the direct costs of those services or those items that we need to procure. If we can go to the next slide. So probably most relevant to tonight's conversation, our insurance enrollment and payment support programs really are centered around helping people understand and get enrolled in insurance that best fits their needs and eligibility. We have a team of assisters that have been doing this work for a long time, some of them for a decade or more, and they are trusted in the community. We have a very multilingual staff, and we also use services to ensure that we can meet people and work with them in the language that they're most comfortable. And because of this and the additional work that we do to help people navigate both understanding their benefits, using their benefits, navigating unexpected bills, et cetera, we have people that come back every year. So there's a lot of trust in the community, particularly in the metro area, of people that rely on Project Access Now to help them navigate this, similar to, I think, a little bit what you were hearing from Shanon. We also run a program on behalf of Kaiser called the Community Health Coverage Program. This is sort of a charity care program that is designed to be somewhat of a stopgap for people that don't qualify for anything else, but it does have some limitations on it and is not a complete replacement for like a donated care model. And then the third program kind of in our insurance enrollment and payment support team is payment support. And this is a program for people who are between 200% and 375% federal poverty level, who cannot afford their premiums. And so we enroll people predominantly during open enrollment, with a few exceptions, and are able to help them pay their premiums, and have also worked with the hospitals to write off deductibles for the population that is enrolled in this program. And that program is really scalable based on kind of where we're able to have funding partners. So, the funding partners sort of set the threshold or the size of the dollar amount that we have each year in order to support people and paying for their premiums. If we can go to the next slide. So a lot of this, I think Shanon did a beautiful job really getting into the weeds on some of the things that we're worried about. So I don't need to belabor that point, but just sort of at a kind of macro level, obviously Project Access Now, our mission from the beginning was to serve and fill gaps in care. And so as we are looking at the ways in which the systems that have been put in place that in many respects we thought may actually sort of help us kind of achieve our full vision as an organization around Project Access Now not being needed, those programs and systems are now being really threatened. And so, similar to what Valdez shared, we just are really trying to track closely where these things are coming, and we are anticipating starting to see more people needing our services. I also do just want to take a moment to kind of re-emphasize something I think Lisa and others have already shared, which is that coverage does not equal access. And I think that with HR1, the other thing I would mention that is a little nuanced, but I think very important to understand is that for people who have, say, plans that are not fully covering what they need, they can have access issues. Some of the conditions in HR1 also are going to actually impact our safety net directly. It will require it, and there's real threat that there will be hospitals and clinics that close as a result of that. And so I think, understanding that healthcare coverage is one piece of the puzzle, but really for people to have access, I think we've been very, we as an organization have often sort of had the hard conversations around what does it actually mean to be able to access the care you need. So let's go to the next slide. So how are we preparing? We have been trying to keep up with all of the policy changes in real time and continue sort of build ongoing conversations with elected officials and others. We work closely with people at OHA. We have connections to the counties. We're really just trying to kind of stay connected and understand the landscape and where things are going so that we can be as prepared as possible to, respond in the ways that we may be needed. Project Access Now has a long history of really being nimble and sort of mobilizing infrastructure, systems, services to meet kind of in the moment the need. And so I think that we really take that responsibility seriously. And so we're trying to not wait until we watch the other shoe drop before we have those conversations. So we're already kind of deep in trying to understand that and anticipate where some of those needs may be coming. As Lisa shared, we work closely with a lot of our safety net partners, and we had a meeting in the fall at the end of October in which we brought about 40 of those safety net partners together for the day to really just start the conversation around what are we worried about, who's going to be impacted, and how can we start to work together to anticipate some of those changes. And so that report is actually available on our website. And when I'm done speaking, happy to drop that link in the chat for you all as well. And ultimately, I think, similar to others on this call, we're really just preparing to fill the coverage and care gaps that may start to become a reality here in Oregon. And if we can go to the next slide. How can you help? We would love to hear from you if you're interested in getting involved or have ideas about how you can support. We would love to hear from you. We do have a mailing list you can sign up for if you want to keep up with us and hear about what we're up to. I believe we send out about quarterly newsletters. Obviously, we're also on social media. We have committees if you're interested in being involved in that way. They are a great way to kind of support us, especially if you have a certain sort of skill set or interest area. We do have a number of different committees. We have our annual fundraiser, which this year is on May 14th, and that information is also available on our website. And then ultimately, I would just say keep, showing up in these spaces, caring about this topic, talking to your friends and neighbors. I don't know about you all, but my experience has been that people don't necessarily know this is going on unless they work in it. And so to be able to be the person that says, hey, did you hear about this? And here's why you should care, and here's how you can help. And if we can go to the next slide. I wanted to just end with a client testimony, a couple client testimonies here. We have many of these. I think number of stories out there in the, like I said, nearly 20-year history of the organization of people who really, it was a life or death moment for them if they weren't able to access the care that we were able to help them with. And I'll just share anecdotally that, and I've been in this role now for about 8 months. I started in May, and in that time, I have already had a number of people approach me and share that either they had received services from Project Access Now, or their mother had, or I had a woman share that she had was part of a support group of breast cancer survivors that really, without PANOW, many of them would not be here today. So just really compelling stories, and I think more than anything right now, we need community support to weather this storm. Thank you, Valdez. I think that's the end of my slides.
All right. Thank you. Put your hands together for Tracy. I mean, all three of our panelists. So, Shanon, Lisa, Tracy, thank you so much. I see real hands. Riddell's got his real hands going, but I also see the electron hands. Thank you all so much. We're just so thankful that all three of you agreed to, just kind of take part in this conversation tonight. I'm going to switch to a little bit of a different view, multi-speaker. We'll see how that looks as we go into our speaker session here, or the Q&A session. So if you haven't put your questions in the chat yet, definitely do that. Claire is collecting them, and we'll make sure that we get to the questions. I've got a couple that we can start off with right off the bat. But, so that we covered a lot. We're talking about the changes that are happening and the financial impacts that's happening to people that are, whether they're covered and qualify for Medicaid or not, with the subsidies ending, and then the difference between free clinics and FQHCs and the different kind of care available, and then Project Access Now, trying to further bridge that gap. My first question is going to go to Shanon, just for a bit of a question. I think you said, Shanon, that 15% of your folks had opted to not necessarily continue insurance. They had to just make that hard decision. They're looking at the numbers, they're looking at their budget, and they're saying 15%. I've seen other places where other parts of the country and what people are saying, 1 in 4, 25%. So it seems like a significant population. I didn't know if you just wanted to touch on that, because I recall you telling me a story about when the Affordable Care Act passed and you needed to put a certain supply in your office. And I'm kind of wondering how things are going now. Maybe you could touch on that story.
Yeah, so I've been in the insurance world for 25 years. I started at a local insurance agency, and the last 13 years I've been doing just health insurance. And when the Affordable Care Act was originally passed, I had boxes of Kleenexes on my desk because I had clients crying because they were able to get health insurance for the first time. And in turn, myself crying. My job is typically really heartwarming because I love helping people navigate this really complex, challenging system. And this year has been the worst year because, as you saw from my slides, every single family's premiums are going up between 50 and 2,500 a month, and it's every single one. And there aren't solutions right now. I like being able to find the program or the discount coupon, the this or the that to help, and there isn't. It's just, this is where it's at. So the families that are coming saying, I'm going to be without insurance next year, are running a huge risk. And it's really all income levels too. It's folks over 400% who are making 100,000 a year, but say I can't pay $2,300 a month for my insurance. It's small business owners whose premiums for their families are going up to over $3,000 a month. It's challenging and so frustrating to not have solutions that we can give to people right now. It's just, we're here with you, and I'm sorry, and through Healthcare for All Oregon and other folks in the state who are working to make changes. But for right now, it's really tough and really sad for those families who are having to go without.
And Shanon, just as a follow-up, you mentioned the 200 to 400% crowd, and Tracy had also mentioned helping people in that 200 to 375% band of above the federal poverty line. I think we talked about in our conversation the other day, it seems like even with Oregon Health, the Oregon Health Plan, and we've been touting 97%. That's the number we always talk about. We got to 97%, but it sounds like even then, like there's this band that often maybe they're not talked about as much as population in that kind of middle range. Can you just touch on that segment?
Yeah, it's so for me, it's, I would say, like 300% and over. And and when you get even over the 400% piece, so some families qualify, even if they are uninsured, they might qualify for some discounts through federally qualified health clinics, through hospital associations. When you get over that 400% mark, you're really not getting discounts or charity care anywhere. So you're footing the whole bill for the things your families need. And that, again, going back to my numbers, 400% for a family of two is $84,000 a year. That is tough when you're looking at hundreds of thousands of dollars of care that you might need.
Thank you so much, Lisa or Tracy. If you wanted to jump in on that, because I think about when we think about who are coming to the Clackamas Free Clinic and Project Access now, or is it if you just wanted to touch on that segment of the population, is it in the small businesses, is it the 200 to 375% level, is it everybody's people above that?
Yeah, I mean, it's definitely, I mean, most people that come to our access our services are working. I mean, predominantly we know are working. Again, lots of reasons why they don't get employer sponsored, but they are working and they don't qualify for OHP. We saw a wave this summer when we raised the minimum wage in the state of Oregon, which was really wonderful. We're trying to raise that. It also kicked a bunch of people off OHP. And so it left out like this group of people. So again, with all these changes, we're going to see this in waves, but anytime there's a change, we see an uptick. And so, but yeah, I mean, we get a lot of self-employed, we get a lot of restaurant owners too. Folks who are actually giving insurance to their employees, but not giving it to themselves. We've actually seen that quite a bit. So yeah, lots of folks, trying to work, trying to do the right thing, but can't afford insurance.
Thank you so much. Yeah, we have a business caucus, so we're reinvigorating because we know that is the case for a lot of small business owners. Tracy, did you want to weigh in on that as well?
Yeah, I mean, I think for us, it kind of depends on the program, but generally our population we're serving is low income, inclusive of that group up to the, 400% FPL. The 375 was sort of a way that, just given the resources available, the funding partners felt like we wanted to make sure it was reaching those most in need. But in other years, we've been able to provide like our premium support for up to 400% FPL. But it does depend on program. For some of our community assistance program at hospital discharge, I don't believe people are being checked for income eligibility, but most often people that need us are not necessarily people that are making more. So that's maybe what I would say there.
Thank you so much. I want to pivot to some of the questions that we've got coming in that have come in during this presentation, and I'm just Shanon, your presentation was particularly sober. The Lisa's and Tracy gave me hope and fills my heart, but that one from Shanon, like that's pretty scary stuff. Question for you, Shannon. First question from Lou Siniger, our chapter, Lane County chapter chair and former HCAO board member and president. Good to see you, Lou. I know you're headed to Labor Caucus. Sure, I'll check your question in here really quick. He said, how will self-employment work, like craftspeople? There's this whole like part about full-time work, your work 80-hour work requirement. Any thoughts? Have you heard anything about folks that are like self-employed?
Not for how the work requirements are going to be rolled out. Last I knew, and Lisa or Tracy, if you know anything else, Oregon hasn't released what that's going to look like. They're working on it right now. And I think an ask would be, we should all be sharing what that should look like, and simple and easy and, less barriers for our consumers as can possibly be. When we're talking about marketplace plans, some of my self-employed folks are in that group of canceling their insurance. If your income might swing $1,000 over the course of the year, right? You don't know where it might land, and that could wind up with you owing back all of your tax credits. You might think it's less risky to just go without. So definitely the volatility of self-employment is impacting folks' decision to enroll in marketplace plans right now because of these changes with HR 1.
Thank you. Lisa or Tracy, anything to add on that one? Okay. One thing I do want to say, folks, you're hearing this, right? You're like, oh, I've got some thoughts on what that should look like. Two things. One, reach out to your legislator now and tell them, if you do Google Find My Legislator Oregon, you can do that and reach out and tell them what you think, because they are kind of figuring this stuff out as we speak. Maybe your legislator, your senator, or your rep is one of those people that the governor is listening to help figure out this whole healthcare conundrum. But the other thing is we have the Universal Health Plan Governance Board in Oregon. It's currently building our Universal Health Plan as we speak. The Universal Health Plan Governance Board has been working for going on 2 years, and those recommendations that they're going to come out about what our Universal Health Plan will look like are coming out in September. So if you're hearing these things that we're talking about tonight and you're like, I've got some ideas on what that should look like, let them know too, because that could be part of the plan that they're building today. Sometimes it feels very big. What should I say about this Universal Health Plan? But I think this is how I think self-insured would work. They would love to hear from you. Next question is from Lori Hoagland. And Lori is our Rogue Valley chapter chair and former HCO board member down there in the Rogue Valley. Good to see you, Lori. And she's a provider NP herself. Quick question for Lisa again was like, so you touch on providers are volunteering at the Clackamas Free Clinic. Do you have other aspects like a typical clinic, like medical records on your computer? I think you said you had malpractice, but can you just tell us again what that looks like for folks that are providing care at your clinic?
Yeah, sure. We look like a real clinic. So, I mean, honestly, it's nicer than my doctor's office. So again, dignity is a big value of ours, and we want it to feel that way when people walk through their doors. Because we're a free clinic, we also, and affiliated with the National Association of Free and Charitable Clinics, we get access to some national programs. So we use Athena, which is our electronic record system, which also talks to other providers in the area. Again, we do a lot of referrals with like Providence for imaging and things. So we're able, we do have a full-time nurse practitioner on staff. We have a medical director that oversees. Everyone is licensed that is through our clinic. So we do have all the same compliance and standards and licensures. Providence actually does supports us with our credentialing. So yeah, come on by for a tour, and all the other free clinics operate the same way. So thanks for the question.
Sounds very similar to La Clinica there, Lori. She's a La Clinica worker. The other thing I was going to ask you while I got you, Lisa, you mentioned that there's only 11 free clinics in Oregon, but there's like 60 in Washington State. It's probably 60. A lot of reasons. All right, how many? 60, right? 60. So yeah. 60 in Washington, 11 in Oregon. Is that because of like policy or statute or like funding stuff, or did they have like a former free clinic person for governor at some point or something? What happened there?
That's a good question. I would also love to hear Tracy's perspective on this. But again, when ACA rolled out, we really wanted to, get care and access and insure everyone. And so again, at our height, we had 97% of folks had insurance, it's amazing. We're down to, as of October, 94%. So we dropped, pretty rapidly last year. So, and I don't know where we're at currently today. I think, again, we really wanted to expand. We expanded the coordinated care organizations. We had a big, ambitious plan. It was wonderful. Again, like you all said earlier, you wanted to work yourself out a job. Like, sure, I would cease to exist. I'll, give that up. But so again, it just wasn't a part of like building the infrastructure. Again, free clinics really started in like the 70s, and they came out of like churches, kind of nationally. That's where they started. And so in some states, actually, free clinics do receive state dollars, and it's partly designed because they keep uninsured rates more like at 87%. So it just depends on the structure. Every state operates a little different. But I want to say, like, just for comparison, yes, we are part of the ecosystem, and we're in a lot of talks with Tracy and the FQs. Like, we're in this together, but there isn't this huge group of free clinics that I just want to point out. It's just different in Oregon. So, Tracy, I don't know if you have any remarks.
Don't know specifically tied to why there's a disparity in numbers. All I would say is I think maybe Washington doesn't have the same kind of waiver and expanded care, and that might have just predicated more clinics. I know that our counterpart up in Washington, there's a Project Access up in Washington, and they have a little different set of services based on the reality that like Washington just looks different than Oregon.
Okay. Hey, Tracy, while you got your mic on, Charlotte Maloney, one of our awesome advocates down in Lane County, has a question. Do you have a funding partner? Does PANOW have a funding partner in Eugene, Springfield?
So the only funding partner we have in that geography is the CCO for the community assistance program, but not for any of the other services that I spoke about or like donated care or anything like that. So yeah, we'd be very interested in if there are other regions that think that they could use our support. We would love to be having those conversations.
Cool. And if somebody here in the style of REO Speedwagon heard it from a friend who heard it from a friend that they want to donate care, are you always like open to those partnerships?
Yeah, I think, right now with the donated care program, which in our case has mostly been specialty care because we take the referrals from like Lisa and other free clinics, FQHCs, hospitals, et cetera. We don't have like an active space for those donators, but we are definitely re-engaging with a lot of our former providers that did donate care and sort of anticipating that we may need to bring that back online again. So we would love to hear from any providers. I will say that's the other thing that was notable to me as this has continued to, sort of get worse. And as we're watching where things are going, more and more providers have been reaching out and just letting us know like, hey, we're here and we're ready to, help when the time comes. So would love to add you to our list if that is you and you would like to help.
All right, one more quick follow-up with Tracy. Do you do anything with Medicare premiums? Do you all do anything to help with Medicare premiums?
Yeah, I saw that question. So the program that we have is centered around Marketplace, and I would have to kind of check with the team who's way more expert than I on some of the detail there. I don't believe we cover or have Medicare plans in that, but I don't want to speak out of turn. And I feel like when I looked at the data, we maybe had one person that was close to or at Medicare age, but for the most part, I think it's people that are in kind of not yet qualifying for Medicare. But that may be a question I could better answer if you want to follow up after with me, I'd be happy to connect you with the real expert with our insurance team.
All right. Thank you so much. You're on deck, Shanon, but I also just wanted to plug, hey, anyone, if you have veterans in your family, you do not have to have been like, a Purple Heart, Congressional Medal of Honor, deployed to a war zone type. Anyone that served in the military is, considered a veteran. So please, if you have veterans also, and you're not engaged with VA care, reach out to the local VA. There's options there. Sometimes even for family members, there's benefits out there too. So check it out. I'm going to come back to Shanon now. Where is the most credible data on the impacts of HR1? I mean, you're sharing obviously some good data here, Shanon, but where does somebody like you go to like look at this stuff and find a source of truth? It's hard to find real news these days.
Yeah, so Kaiser Family Foundation is always a great resource. Beyond the Basics is another one I've used a lot since the beginning of the ACA, and then OHA. there wasn't much updated data because open enrollment ends tomorrow. So what I expect over the course of the next 30 days or so, all of that data will be aggregated and hopefully shared out. Although the federal government would be the ones doing that, and I don't know that that's going to happen. So, yeah, but so Kaiser Family is a great resource.
Thank you. Lisa or Tracy, that was Mike Ing's question. Any additional thoughts on good sources of data to go nerd out on this stuff?
Yeah, Kaiser's great. There is a National Association of Free and Charitable Clinics. We share some different data reports. I mean, yeah, I mean, we track OHA, but again, there is a delay there. You know, it just takes time.
Gotcha.
Yeah, I think we use similar data sources. I mean, there's other data sources more just around care that are available, but I think in terms of tracking what's going on, I would agree. Like Kaiser Family Foundation tends to be where we go for some of the most up-to-date, at least national information.
Gotcha. And y'all, if you go to Kaiser Family Foundation's like website, you can sign up and subscribe to different types of newsletters. Not even just like one newsletter. You can get it daily, weekly. It's kind of cool. Check it out. We have another question here. I'm going to probably butcher your name, Matri Lamb. Matri wants to know, where can we find a list of all the free clinics in the state? Maybe that's one for you, Lisa. You said there's 11 of them. Who are the other 10?
Yeah, I'll link it in the chat. There's Salem Free Clinic, they're large free clinic. There's Cascade, which is in Bend, Southwest Washington. There's Borland, which serves Washington County, but I'll send a link. It doesn't cover it all. We're working on a new website, as a collective, so we're all independent, but we have a consortium. But I will put a link in the chat.
All right. Thank you. We have about 5 more minutes. There's a couple more questions here. Cynthia Johnson has a question. The chronically ill and disabled are being very hard hit with work requirements they cannot meet. How do you think we should help these groups in Oregon this year? I don't know who wants to jump on that one.
Yeah, I can say it looked like that those folks wouldn't necessarily be impacted if they truly do fall under those categories. The work requirements applied to what we call the expansion population, so folks that weren't historically eligible for Medicaid before the Affordable Care Act, and now are. So folks typically who don't have disabilities, who don't have young children at home, who aren't pregnant. So like the potentially able-bodied adults is who these work requirements seem like they're impacting. But I would assume OHA will have more information for us once they get this together and roll all of that out.
Gotcha. Thank you, Shannon. Speaking of OHA, Lindsay Couch Letterer wants to know, do we know if Oregon Medicaid will be changing their covered services, the line, for those who are still lucky enough to stay on Medicaid? I know that they're trying to figure out, do we provide the same amount to same people but less services, or the same amount of services to less people? Any indications of that that anyone's heard about? I know that I think that's what Bruce Goldberg, Dr. Bruce Goldberg, friend of HCAO's and yours, is helping the governor figure out. Go ahead, Tracy.
I don't think we know yet. Yeah, I haven't heard anything. I would just say that's what I was going to say, is that I know Dr. Goldberg is working with the group that's trying to figure out a lot of that. So
we love Dr. Goldberg, former OHA director, member of the Universal Health Plan Governance Board, and a hell of a guitar player. He plays the HCAO Garden Party every year. So him and the Homebrew Band. Another quick question for Tracy before we start moving towards wrapping up. Lindsay also wanted to know, could you provide examples of who's providing funding support to PANOW in the region? Just a few examples, maybe.
Yeah, so historically, our funding has predominantly been provided by health systems and CCOs, so definitely very kind of healthcare heavy. And then, of course, we do receive donations and we apply for grants. I think, with the shifting landscape, we're really interested as well in kind of wanting to look at ways to engage with others who may be interested in funding the kind of work that we do, because some of those arenas, as we all know, everyone's under a lot of strain. So yeah, but historically and kind of current state still, our core funders are health systems and CCOs.
Well, apparently I don't know the difference between a harmonica and a guitar, because when Bruce plays the harmonica, and I swear he played the guitar when he wasn't playing harmonica, but okay. I guess I need to be facing the band and not the crowd with my dumb jokes. All right, we'll leave it to Gary Oxman on the bass. Okay, there we go. There's one. Well, thank you all so much again. I think that's all the time we have for questions tonight. You feel free to send questions to the folks. They share their information on the slides. We'll see. This video will be made available. Panelists, you have to let us know if you're okay with the slides, going out as well. That might be a nice way to have the links and the contacts. If you all are cool with that, looks like maybe you are. Cool, awesome. So we will get those out to everybody. And yeah, just thank you so much again for dialing in, making this a great conversation tonight. We're looking forward to more webinars, everyone, coming up in the next few months. We have some PSU students who are even going to help us with that organizing, but there will be more exciting topics coming soon. Before you go, I just want to thank you all again for attending. And it wouldn't be a great meeting without a call to action. So I have a few actions for you to consider. So this is kind of a choose your own adventure, a little bit of a call to action buffet. The first one is, please go, if you haven't already, go to HCAO.org and join the movement. Claire's going to drop a link in the chat there for you, but HCAO.org. If you're watching on YouTube, HCAO.org, and join the movement. Adding your name to a statement of support helps add to our list of supporters and show that strength at the statewide level, the popularity of this grassroots movement. We have over 45,000 folks who have signed that statement and are supporting this work. And you can also become a member if you'd like. It's kind of like that, OPB membership thing. For as little as $5 a month, cup of coffee a month, $30 a year, you can become a paying member and invest as a good cause shareholder of universal healthcare at HCAO. We're 90% funded by individuals like yourselves, and every dollar goes towards our organizing and advocacy efforts. Again, at HCAO.org, you can become involved and hit the Take Action button. There's a ton of ways to volunteer, to take action, to help get involved, write a letter to the editor, join our drummer circle, helping us talk to legislators about the Universal Health Plan Governance Board and other legislation. We're going into the short session. There might be a couple things that we want to weigh in on, and it's good to have our drummer corps. And we actually just started a student chapter. We have a high school student chapter made up of high school students, started in Lake Oswego, but it's building quickly statewide. So if you have young activists in the household, please go to our HCAO.org website and join the student chapter, and they'll be able to connect with other students virtually around the state who are activists about this. Remember, if we can get this on the ballot in 28, the sophomores of today will be able to vote for their healthcare future. We also want to encourage you to make your voice heard at the Universal Health Plan Governance Board. The Universal Health Plan Governance Board is designing the plan as we speak. Mary Lou Henrich is on the call. She's a member. These are real people. We know them. They're designing the plan as we speak, and it's going to be published in September of 2026. But it's not too late to make your voice heard and shape the outcome of this, whether it's the financing, whether it's the coverage, whether it's how are we going to treat people that work for themselves. So let them know. Like I said, those recommendations are coming out later this year. And now is the time to make your voice heard. And if you're like, I'd like to, but I don't know how to do it. I've never done that kind of thing. Hit us up at info@hcao.org and we will connect with you. And we've got tools and templates, and we can make it easy. So again, we've got a great community right now. One thing that I've been hearing a lot from our activists and volunteers is that these are dark times, my friends. There's a lot going on, and with Facebook and Instagram, and even with that stuff, sometimes you feel connected virtually, but you still kind of miss that interpersonal connection and that good old-fashioned community that a lot of us grew up with. There's a way to find community and connect, and for a good cause at HCAO, getting involved with as a volunteer with a local chapter, on our committee. You can meet other like-minded people, make new friends, and help us achieve universal healthcare. So please email volunteer@hcao.org or go to the website and click the volunteer button. There's a million things you can do, from knocking on doors to licking envelopes and putting stamps on things to entering data. We need it all. We only got a handful of staff. We're kind of like the free clinic. We got a small amount of staff and a whole lot of volunteers, and you could be one of them. So again, we just want to thank you for making tonight just such a wonderful evening. Thank you for your passion, for your advocacy, for your curiosity, and being an ambassador. Like Tracy, Lisa, and Shanon said, every one of us has our connections in the community. And the folks out there that are being rocked by these insurance changes and having to go without care might not know about some of the solutions we've talked about tonight. and they might not know about the solution of tomorrow, which, yes, is universal healthcare. So thank you all. Happy New Year. 2026 is rough so far, but we'll get through it because we're all here together. Thanks, everybody, and we'll see you at the next webinar. Have a nice evening.